Hello, and thank you for joining our educational webinar tonight with Dr. Jeremy Turlington and Salvatore Carbone, Dr. Salvatore Carbone, who will discuss the importance of men's heart health and ways to avoid heart disease, including tackling risk factors by recognizing and reacting to symptoms, as well as how lifestyle, diet, and physical activity can impact overall health. I'm Pauline Jankowski, VCU Health Poly Heart Center Marketing Communications Manager. Before we begin the presentation, I would like to first make note that we will hold all questions until the end. Please feel free to drop in any questions you may have in the Facebook comment section throughout the event, and we will address them during the Q&A portion. Now, a bit about our speakers. Dr. Jeremy Turlington is a cardiologist at VCU Health, specializing in echocardiography and cardiac critical care. He received his medical degree from Eastern Virginia Medical School and completed his residency in internal medicine, followed by a fellowship in cardiovascular disease and critical care medicine at VCU Health. He currently sees patients downtown, Stony Point, and virtually. Professor Salvatore Carbone obtained his BS in nutrition and dietetics at University of Rome, then completed a MS in cellular and molecular nutrition at University of Urbino Carlo Bo in Italy, and a Ph.D. in molecular medicine and metabolism at University of Rome. His research investigates the role of different dietary interventions in body composition, phenotypes, and cardiorespiratory fitness and energy metabolism in patients with obesity and heart failure, with a focus on heart failure and preserved ejection fraction. Thank you, Dr. Turlington and Professor Carbone, for joining us today. I will now turn the show over to you.
Thank you, Pauline, and thank you, Salvatore, for working with me tonight. And thank you, everybody, for watching. My name is Jeremy Turlington. As Pauline said, I'm one of the cardiologists here, and we're going to start talking about heart disease, mainly as it affects men, because June is Men's Heart Health Month. Before we go any further, I have no disclosures, anything like that to go over. Objectives, you can read the objectives. And I really want to bring up that, one of the issues that we have is, I know some of my predecessors have talked about some very kind of trending, cool topics, how COVID is related to the heart and such. And when Pauline asked me to give this talk, I was like, oh, that's really interesting. It almost doesn't seem very exciting. But I think this is really important because as we've been bombarded with COVID and all the things over the past year, I think some of the chronic issues that we deal with in America, such as heart disease, have been put on the back burner. And it's really important that we talk about what heart disease is, talk about the actual definition, because it's not necessarily crystal clear. We're going to talk a little bit about how heart disease affects Americans and especially men. You'll have to bear with me for a second. I love the idea of a little bit of historical nuggets that go along to settle this up, so I have a little bit of a story to tell. We're going to really focus on risk factors, what it means to you and the public, what your risk factors are, and how we can try to control those. We're briefly going to talk about the symptoms of heart disease and how you know when you really should talk to your doctor. And then I'm going to finish up by discussing how you can understand your own risk for heart disease. So the definition of cardiovascular disease or heart disease, there are a lot of terms that are used interchangeably, as you see even on this slide. And from the American Heart Association, really heart disease in and of itself is a collection of diseases of the heart and their blood vessels. They can start with a heart attack. You can also be a stroke, which is actually, extra cardiac. It's not from the heart, it's of the brain, but the blood vessels there are to be concerned with. Heart failure, abnormal heart rhythms called arrhythmias, and then heart valve disease. If you'll take just a second, and this is kind of lame, but I have an analogy of the heart that I think it's like a house. And I use this with patients a lot, the house that has walls. If the walls aren't working well, then you have heart failure. If the doors or the valves aren't working, that's a valvular disease. If you have an electrical problem, that's an arrhythmia. And if you have a plumbing problem, that could lead to a heart attack, a blocked artery. So I think when we break this down, it helps patients think about it. And what you realize is that all of these are intimately related, and one can beget another problem. We have to talk about how they are interactive with each other. Really, when it comes down to, there are forms of arteriosclerosis and atherosclerosis. Again, terms you hear from your doctor in the media. And really, arteriosclerosis is any blood vessel over time can become hard and stiff, arteries by nature are very elastic and almost rubbery. They can move, they can become larger and smaller to help propel blood. But as people get older, theoretically, those arteries become hard and stiff. A subset of that is atherosclerosis, and that's when you start getting, as you can see on this slide, deposition of what we call plaque, cholesterol, and other fatty buildup in the artery. Now you have a hard artery that can't relax, can't dilate, can't get bigger. And then it starts becoming closed in from the inside with this plaque. And eventually that can lead to narrowing of the arteries and eventually to a heart attack, which can lead to more problems down the line. Now, first of all, some of this, I'll tell you, like I said, this isn't a really cool trending topic, but these are big deals, and y'all are going to know some of this, but I want to bring some of this to light. Heart disease, as of 2021, is still the most common cause of death in America. One person dies every 36 seconds in America from heart disease. So by the time we go through the slide, 2 people have died in America. 655,000, almost 700,000 Americans die every year of heart disease. Now, I don't want to make light of it. It's a serious issue that we've had with COVID, but think about in the past year, at about a year, we had about 400,000 Americans die of COVID at the year mark, which was huge. And we had almost 300,000 more people have heart disease and die of that every year. This is still, in our country where we have so many medical advances, a big issue that we need to stay on top of and really pay attention to. This is a great map and this is for men's heart health. So I want you to look, this is men over the age of 55 by thousands, the number of people that die on a year-to-year basis. And I want you to take a snapshot of this in your mind and look at where the deep red means more people are dying, and look at kind of the pattern where it kind of goes to the Sun Belt here in the southern states. I want you to remember that because we're going to talk about that with risk factors later. Now, the epidemiology of heart disease. Again, in the end, men are more likely going to have heart disease and have big complications of heart disease, such as death, more than women. Of course, that happens with cancer and other accidents too. But if you look at this, we're talking about in this study, and this was from, I said Varani, it was a study that was done printed in Circulation in 2020. There are more men that die of heart disease than women every year. If you look at this looks like over the past decade, or actually the past century, that heart disease starts to really peak, and it peaked in the 80s. And then we start having a decrease in the number of people that die of heart disease every year, which seems somewhat beneficial or reassuring. But you look in the past 5 years or so, those numbers are creeping up again. And that may have to do with obesity and diabetes and physical activity, some of the topics we're going to hit on a little bit later. And then if you look here, I honestly don't understand what's going on with Romania, but in America, compared to other developed countries such as Israel and Norway, the risk of death from heart disease is much greater than men and women. So again, not only does it affect all Americans, it really affects men. And I think we should all be aware of this so we can try to control our risk factors and reduce our risk for heart disease. So on to the history. In the 1940s, heart disease, as you remember from that slide I just showed, was the #1 cause of mortality in America. It caused almost half of all deaths. Now, granted, it doesn't cause half of all deaths now. It's still the leading cause, but as cancers have increased, the proportions have changed. What's interesting is in 1932, when President Roosevelt was running for election, he was found to have a blood pressure of 140/100, which we all know, we'll go over a little bit later, is considered high blood pressure or hypertension. And by 1941, his blood pressure increased to 188/105. When he was in office, when he came into office, he actually got an otolaryngologist, an ear, nose, and throat doctor, to be his primary care physician as the president, because he was more worried about throat issues from speaking and headaches, which may have been related to his blood pressure. All this while he's working as president, as we know, for what ended up being almost 4 full terms, Winston Churchill was a contemporary that noticed that he always looked very fatigued and was worried about him. In 1944, while we were planning the invasion of Normandy to free Europe, his daughter actually was so worried about him that she had him admitted to Bethesda Naval Hospital for shortness of breath when he exerted himself and abdominal distension. And there was a cardiologist there, a young cardiologist, who noticed he looked a little cyanotic, a little blue, and was worried that he had at the time called hypertensive heart disease. There really were no treatments for it at the time. besides lowering the sodium in his diet and a medicine called digoxin, which we still use every once in a while. But he sent him home on that, and he felt a little better. But then a year later at the Yalta conference, the war is over. We're trying to figure out how we're going to rebuild the world. Winston Churchill again saw him and spoke with his doctor, his personal doctor. And Churchill's doctor said, I think Roosevelt is a very sick man. He has all the signs and symptoms of hardening of his arteries. A few months later, at only the age of 63, he died of a cerebral hemorrhage. Again, stroke, blood vessels, this is all interrelated. And at the time he was admitted to the hospital, his blood pressure was 300 over 190. Those are stunning, stunning numbers. Now, while he was president, the National Institute of Health was founded. And because of his death in 1947, the National Heart Act was passed by Truman, and it actually it developed the National Heart Institute. And then it really wanted, the point of the National Heart Institute was to study the expression of heart disease in normal people, to try to figure out what factors they are that predispose normal people to developing heart disease. And they're going to follow them over a long period of time with clinical exams and laboratory findings. And it's always beneficial to have Harvard and Massachusetts General on your side, but they actually argued to get it brought to Framingham, which is a small city of about 20,000 people who are farmers that become more industrial, to study the risk factors related to heart disease. Now, the Framingham study has lasted for over 60 years, and not only looked at that first group, but looked at their kids and their kids' kids. We've gotten a ton of data that we use. This is one of the original papers, and the cool thing, if there's a cool thing about this, is the term risk factor was coined by the Framingham group. Now you hear about risk factors for heart disease and car accidents, whatever it may be. That term didn't exist before this paper. What I want you all to look at here is down here, we're looking at the group in Framingham, this original study, and young men aged 30 to 45, which I think is a significant proportion of this group watching tonight. Of that group, of 1,000 patients, 25 had heart disease. You know, well, those numbers aren't terrible, but look at women the same age, 2. Heart disease is very prevalent in men back in the 40s, 50s, 60s, and much more prevalent at younger ages, which is why it's so concerning that men are getting heart disease. We really need to figure out why. As people age, women do eventually catch up, but not to their 60s or 70s. And you look at this group, this was a younger group, 45 to 62. Men still outnumbered women with heart disease 2 to 1. So again, what it showed was in the young group, under the age of 45, young men were much more likely to have heart disease than women. And at the time, what they were also finding is that there were some quote-unquote risk factors. High blood pressure was much more common in the younger men, as was elevated cholesterol. And we're seeing that happen, and then people are having heart disease. So we're seeing a temporal relationship that these disease processes may be leading to heart disease in young men, and then in men as they get older. So what are our risk factors? Risk factors, unfortunately, are advancing age. As we get older, we're more likely to develop heart disease. As I've said a couple of times now, and that's why you're listening, being a man increases your risk. And we'll talk about why that may be. High blood pressure, also known as hypertension. High cholesterol, especially that LDL or the bad cholesterol, hypercholesterolemia. Obviously, tobacco use. We're aware of this in 2021, and yet there are still quite a few people smoking. We're learning more about how physical inactivity causes problems with the heart, and how being overweight or obese, or even other measurements within that category of obesity might affect heart disease. Now, before we talk a little bit more, we need to know what are non-modifiable risk factors and what are modifiable. Non-modifiable, you can't change. We all get older. We are our gender. We are our parents' children. So if you have a family history, you're kind of stuck with that. But modifiable risk factors, Dr. Carbone and I are going to talk about what can we change to help make you healthier, or what can you change about yourself to make you healthier? And then there are these contributing factors, things that we're still learning about that may be related or associated to cardiac disease, but we don't know exactly how they're related, if they're truly causal at this point in time. So looking here, this just shows what are, non-modifiable and what modifiable risk factors we can have. What can we intervene on to reduce risk of heart disease. So, there, again, I'll say this over and over, I'm trying to hit this point home. Men are at increased risk of heart disease when compared to women. Based on these studies, more Framingham and other studies, we found out that women develop heart disease approximately 10 years later than men. So women have their first heart attack later. The other thing we find is men have an earlier incidence of other risk factors such as hypertension, high cholesterol, diabetes, et cetera, that can set them up for heart disease. Another interesting fact from Framingham is, unfortunately, when men get heart disease, what we come to find is their first presentation a lot of times is a heart attack, or back in the 60s, 50s when they were doing the study, was actually death, was sudden death. Women usually present with symptoms. They're having chest discomfort or shortness of breath. It's almost a way to intervene upon it sooner. Now, things have changed over the past 60 years, but that still is the case. Now, there is some thought that estrogen, what women have, the hormone for women, is actually somewhat cardioprotective. It can reduce epinephrine levels, which is a hormone that stimulates your kind of flight or fight response. So it gets the heart rate up, gets the blood pressure up. So there may be some help there. It also can, we call, down-regulate or suppress genes in the heart so they don't react to those stress levels. So maybe they're protected from some dysfunction. The men don't have some of these innate protections. But a lot of studies have happened over the years, and this one may be a little dated, going back to 1997, but they say that though we think this and we see this, this hasn't been well borne out. What we can tell is that women catch up to men postmenopausal when their estrogen levels drop. That's when they have more high blood pressure, high cholesterol, heart disease. But we haven't quite made that causative factor yet and figured that out. So again, remember that slide I showed you earlier about death in men of 35 or more from heart disease and where the most deaths were. This is looking at hypertension in 20-year-olds and older. It's roughly the same distribution. When it comes to high cholesterol, roughly the same distribution. When it comes to smoking, saying who smokes, roughly the same distribution. Nevada kind of seems to be the outlier out west. When it comes to physical inactivity, people that over the age of 50 who say, I don't exercise that much, and we'll define that much later, roughly the same distribution. And then when you look at obesities, we know if you look at these slides over the years, America becomes more obese, but it's roughly the same distribution. And what I'm proposing is that these risk factors we see affect both men and women, but men, it's in that same area. Virginia, we've always been seen to be a little bit safer compared to some of the other southern states. But the risk factors there and probably lead to some premature coronary disease. So how do risk factors affect the heart? And that's what I think. People know high blood pressure is bad. They know smoking is bad, but how is it bad? Hypertension and physical activity reduces that elasticity, that rubber effect of the blood vessels, and allows them to get harder. When the blood vessels get harder, that higher pressure, the blood pressure is a weight, the heart is a muscle, it increases the workload on the heart. And unlike your biceps, where you want them to get bigger by lifting more weight, when you lift more weight in the heart, the muscle gets thicker, but it has to work harder because it has to pump more blood. Eventually, over time, this is not a sudden finding, this is over years, the heart starts to dilate and become larger to make up for that pumping mechanism. And eventually it starts getting tired and weakened some. When that high blood pressure is exerting its effect on the blood vessels, it actually causes damage to the lining of the blood vessels, which allows cholesterol to get into that lining or under the lining. And over time, the body attacks the cholesterol and forms what we call these foam cells. You don't need to know that. Usually if the cholesterol gets in there and starts swelling kind of underneath the layers of the arteries, and that further narrows to the heart. The artery is firm, it's distended, and now it's starting to close in from the inside, reducing blood flow through the arteries to the heart. Furthermore, when people aren't active, when they're obese, this exacerbates that stiffness of the arteries and on the muscle itself. There's more workload on the heart, causing further stress. It's a real deleterious cycle where one problem begets another and it kind of cycles through. Patients who are obese usually have higher sodium levels and they retain more fluid. So now as the heart having to work hard to pump against that high pressure, it's also having to pump harder to move that fluid, that blood through the body. And it's another kind of whammy hitting the heart at the same time. And then, when patients are obese, and this is a lot of Dr. Carbone's studies, this is what he works on, and we've worked together some over the past decade together. Obese patients have more inflammation in the body. That can destabilize those plaques of cholesterol in the arteries. And once that plaque destabilizes and ruptures, that's when heart attacks occur. Finally, I haven't talked about smoking. We all know it's bad. Why? Smoking multiplies the effects of everything I've just told you about. The arteries become even more hard. Heart rate increases, increasing that workload on the heart. The good cholesterol, HDL, drops while the bad cholesterol increases. And blood actually becomes more viscous, almost more sticky. And so when blood becomes more sticky, you're more likely to have problems with heart disease down the line. So when it comes to these risk factors, you have to go back, and it's hard now. I just turned 42 myself, and I'll be free to admit that. But you go back to puberty, boys, young men are starting to notice have high blood pressure starting in their teens to 20s, as that slide showed. So your arteries have a chance to be harder at younger ages. Women don't catch up until postmenopause, which is roughly 60s, so your 60s or 70s. So they have years where they're playing catch up before it really has an issue. I talked about the effects of the sex hormones, estrogen, androgens, testosterone. There's a thought that testosterone can be deleterious too. And then as you get older and your testosterone drops, that means the blood pressure can go up further, and it can cause that. But no studies have been shown, at least from my reading, that low testosterone and actually increasing your testosterone, going to your doctor saying, oh, I heard about low T, should I take testosterone? That has not been shown to lower blood pressure in men. Men also have other behavioral differences, whether they don't exercise as much, whether they eat worse food, whether they increase their sodium intake, they smoke more. All those things are other behavioral differences for men that can increase the blood pressure and cause increasing heart disease. This is just another slide. And again, I say this 2 to 3 times, but I think you should know when you hear it, you'll hopefully stick. Starting in your 20s, men are more likely to be hypertensive, percent of the population. And, a quarter of all men 20 to 35 have high blood pressure, while only about 10% of women, and it keeps going up. And you can see here, not until the 60s do women actually catch up and overtake men for for high blood pressure. This is looking at smoking. Clearly, the risk of death from heart disease when you're younger is up much higher as you smoke. What we actually see is as people get older, though, the actual death rate just continues to climb. I don't know if I can really explain this little blip in the mid-70s, but extra deaths due to smoking causing heart disease goes up throughout people's lifespan. So stopping smoking earlier has a much bigger effect and reduces your risk. And then obesity. So obesity, for years, the body mass index, the BMI, has been shown to predict heart disease. But are there better measurements? Waist circumference, but actually waist to hip ratio is actually better at predicting the risk of heart disease. There are people who are defined as normal weight obese. You have a normal weight, your BMI is not that elevated, but if you carry that weight around your middle, the quote unquote dad bod that we've all heard of, and you can see this slide here, you're at risk of low good cholesterol, higher bad cholesterol, inflammation, resistance to insulin. You can't use sugar, glucose intolerance, et cetera, and that can increase your risk of heart disease. And then this actually goes to look at this. If body mass index can predict, and the men are the dark squares, women are the gray diamonds. If it can predict heart disease as people's BMI goes up, look at their waist to hip ratio. Really shoot that. You can really tell by waist to hip ratio when it gets above 0.95, it starts to really take off here. And that can predict your risk of heart disease. So what are the symptoms? I only did one slide. I think we know this, but chest discomfort, chest pain. Not everybody reads the textbook, but the idea that you're having chest pain and pain that is a squeezing pressure sensation comes on with exertion, goes away with rest, maybe radiates up to the jaw, down the left arm. That's a real warning sign for heart disease. I always joke, if I got $1 for every male patient that said, oh, it's just reflux, it's just indigestion, I wouldn't make a lot more money, but I get 1 or 2 patients a week in our coronary intensive care unit who come in for heart attacks. Like, oh, it was just indigestion. I sat on it for a few days. But if you're having those symptoms or any chest pain that worries you, you should talk to your doctor. Shortness of breath, also known as dyspnea. If you can't exert yourself without getting short of breath, that's a sign of maybe blocked arteries or weakening of the heart. Fatigue is a general symptom. We all get tired from time to time. But what I really want to hit on is if you can't do your activities, if you go to cut your grass and you push that mower and you feel good, but a few months later, like you need to sit down midway through to catch your breath, or you can't walk the stairs of your house, or whatever it may be, that's the fatigue I'm worried about. When you're having symptoms that's reducing your ability to do your activity, that's when I worry about how is your heart functioning. Swelling of the legs, when the heart gets weak, fluid backs up, can back up into the legs. Palpitations, be it irregular heartbeats, fast, slow, whatever it may be. If you notice your heart beating irregularly or beating strongly, you should let your doctor know you could be having abnormal heart rhythms. And passing out, also known as syncope, is a sign of abnormal heart rhythms. So knowing your risk is the first way to reduce your risk, knowing your risk factors. And once you know your risk factors, you can, those modifiable risk factors, look at lifestyle, look at medications. I'm not going to go into great detail because I want to save time for questions and such, and definitely Dr. Carbone, but we need to talk about this a little bit. High blood pressure. How do you do it? What do you do? You know, it consists of the systolic. The top number is when your heart is squeezing. The bottom number is when your heart relaxes. You really should be sitting comfortably with your arm at heart level, sitting on an armrest. Uncross those legs. Sit for 5 to 10 minutes. Use a manual cuff, an automated cuff, whatever you have. Do it. Be consistent. You know, even you come in the doctor's office, you may be rushed. You may have run up the stairs. That's probably not the ideal time, but we check it because that's what we do. But you could be smarter at home. Keep a log. Let your doctor know about that. Normal blood pressure really should be less than 120/80. It's now, this is by the American Heart Association in 2017. This is controversial. Saying people have high blood pressure now at 130/80. It used to be 140/90. But it really is, especially at younger ages, we need to intervene sooner to potentially reduce your risk of heart disease. And if you get to 180/120, that's a crisis. Your doctor should probably send you to the hospital. And this is what FDR was walking around with while he was serving our country as president. So that's something to think about. High blood pressure medicines. There are more blood pressure medicines than any other class of medicine other than antibiotics. There are tons of subclasses. Diuretics like HCTZ or furosemide. This is not an all-inclusive list. This is just to give you some examples in case you're on these medicines. Calcium channel blockers, amlodipine, diltiazem, ACEs, angiotensin, ACE inhibitors, or ARBs is what we call them, angiotensin receptor blockers, lisinopril, losartan, beta blockers, metoprolol, carvedilol, dilators, hydralazine. These are all medicines that your doctor may use to help control your blood pressure. You should really see your doctor on a yearly basis, even if you don't have heart disease, to check your risk factors. Ask to check a lipid panel to know your cholesterol. A hemoglobin A1C, it's an average of your blood sugar, so we can see if you have diabetes. This is a really busy slide, and I realize that. I don't expect you to remember this. When you're talking to your doctor, if that bad cholesterol LDL is greater than 190, you really need to start talking about being on medications. If it's less than, then your doctor, through a risk calculator, looking at blood pressure, smoking, diabetes, et cetera, can talk to you about what your risk of heart disease is and whether you should be on medicines. Medicines include statins like atorvastatin or rosuvastatin, absorption inhibitors, ezetimibe, also called Zetia, or the newest medications, PCSK9 inhibitors, alirocumab, or injectables that really drop that cholesterol. And then knowing your BMI, but really that waist to hip ratio. You get a tape measure, you breathe out, and you should measure your waist. The waist is higher than we think. It's about 1 inch above your navel. You measure there, and then you measure across the widest parts of your hips and divide one by the other, as you can see here. If you get above, 0.95, that's average, but above that, your risk of heart disease goes up. So you should think about what you can do to lose some weight if you have those measurements. Finally, when you have, what can you do? You can help. Activity, moderate exercise, walking regularly. It's a lot. It's in 2.5 hours, but averaged over a week. going to push that lawnmower, working in the yard. That's a great way to burn an hour or two of time right there, and that can be very helpful. If you vigorously exercise, play tennis, go running, whatever it may be, you can cut that time down. Weight, there are many gimmicks out there, and I hate to say gimmicks, but really it's decrease your intake and increase your output. But watch those sugary snacks and drinks. Avoid trans fats. Talk to your doctor about what kind of food, or talk to a nutritionist. I know a great one coming up. They can help you figure out the right medicate or the right food to eat to help you lose weight. I would like to get this into a little card. You can almost print this up and put it on your refrigerator or whatever, but know your blood pressure, systolic, diastolic. Know your cholesterol, your total cholesterol, good and bad. Know that A1C, your BMI and waist to hip ratio. Write down your activities. If you know this, when you go see your doctor, you can show him or her this. Say, what should I be worried about? What can we do to reduce my risk? If you have that information there in front of him, it can make, or her, it can make things so much better as far as trying to figure out your risk and what can we intervene upon. And finally, about 2 years ago, the American Heart Association created this path to improve your cardiovascular health. And it's simple, Life Simple 7. They talk about smoking status, physical activity, weight, diet, blood sugar, cholesterol, blood pressure. That's the website. You go through and they give you some real easy nitty-gritty activities you can do to help make your heart safer while you're talking to your primary care doctor or your cardiologist. I hope that was very helpful. It's a lot of information in a small time. I'm going to turn it over to Salvatore, and I look forward to answering questions in just a few moments. Thank you very much.
Okay, thank you very much, Dr. Turlington. That was really a great overview of cardiovascular disease in men, but I think it's really relevant to men and women, and hopefully now with this second part of the presentation, we can find some potential strategies, or at least non-pharmacologic in this case, to potentially reduce some of the, improve some of these risk factors with the goal of eventually reduce the risk to develop hypertension and heart attack and stroke and diabetes in some cases. So I only have a couple of slides with some figures, but I think it's really important to show, I really wanted to show you this slide. And what is the slide is essentially telling us is that over the last few years, if you look at the number of deaths in the United States, you can see that dietary risk account for the majority of the death in our country. And this is extremely important because certainly dietary risks are modifiable, so we can improve our diet, and possibly recent data suggests that we could prevent up to 45% of all deaths related to diabetes and stroke and heart attacks just by improving our diet. Dr. Turlington has shown you what Life Simple 7 is. And I strongly encourage all of you to actually go online and fill out your Life Simple 7. You can put your values, and then you will have a score and some tips to improve some of your score. And the reason I wanted to show you this is that, as you can see here in both children and adult, what is called a healthy diet score, it's actually the risk factor that is the least achieved in the US population. We would love to have everything blue. Like, for instance, as you can see with smoking, we're actually doing pretty well. You can see here almost 80% of people actually are not smoking right now in the United States. But when you look at diet, the blue is very, very small. It means it's only 0.5% of the US population is actually achieving what is considered to be a very healthy diet. So room for improvement, which is on the one hand a positive because we can do so much better, but on the other, it suggests that really we need to work hard to improve these numbers. And so how do we improve our diet? Luckily, there are the American guidelines. So the dietary guidelines for Americans that are released every 5 years, and these are developed by a number of experts. It takes several years and so much work to put together these guidelines that allow to prevent risk factors in the first place. So we always talk about high blood pressure, high cholesterol, obesity, but treating them is really hard while we could actually prevent them in the first place. So what is called primordial prevention, so the prevention of risk factor. And these are free, they can be downloaded online. They are really good, and now the newer guidelines, they also include nutrition for children, pediatrics, and pregnancy, because we know that risk factor start from the pregnancy, and so we need to do something already earlier in pregnant women. But what I wanted to also mention today is that when we think about diet and nutrition, we always think about restriction. When you talk about someone and they say, "Oh, I'm following this diet, but it's so hard to follow." And in reality, when you look at the dietary guidelines, they suggest that yes, the majority of the calories in your diet, so approximately 85% of the calories from your diet, should come from a healthy food, food that are nutrient dense, meaning that they have a lot of, in a small volume, they have a lot of nutrients, healthy nutrients like protein, healthy fat, low sodium, vitamins and minerals. But there's also room for approximately 15% of unhealthy calorie in your diet. So it is okay to include some unhealthy, about 10 to 15% of calories in your diet that are not necessarily healthy, as far as we're able to remain within this 10-15%. Now, there is also a little bit of a focus, especially in the United States, on calories, on counting calories. And this sometimes takes away the focus from quality to quantity, which is not necessarily the way to go. For instance, even our nutrition facts are actually emphasizing the number of calories of a specific serving. But now we know very well, for a number of clinical studies done in the last decade, that quantity or number of calories alone are not sufficient. In fact, you could have a snack made of nuts, so you can have a handful of nuts, which could be about 200 calories, or you could have like a protein bar or a very unhealthy bar, which gives you about 100 calories. Clearly, in this case, nuts would have been the choice, the best choice. But if you only looked at calories, the bar would have probably been what many individuals would have chosen, because they had lower calories. And so we need to learn to read the nutrition facts. And hopefully today we'll focus a little bit on sodium and a little bit of fat. I don't think we have time to talk about sugars, but if anybody has questions, we can address that in the Q&A session. Why is it important not just to count calories? Calories are important, right? Because if we eating more calories than we burn for a long period of time, we will gain weight. On the other hand, if we eat less calories than we burn, then we would lose weight. So that's a strategy to lose weight. But not everybody needs to lose weight. And some people also, if they have a normal weight, they can still be unhealthy. They can still have risk factors such as high cholesterol, high blood pressure, impaired glucose, or prediabetes. So we really need to be careful, not just about calories, but all the nutrients that the food can provide. And so does everything that we eat have calories, and are all low-calorie food necessarily healthy? So this is a little old nutrition facts, but I wanted to show you, to compare these two nutrition facts. And both are frozen peas, and you can see that they provide the same amount of calories, 60 calories and 60 calories. They provide the same amount of total fat, same amount of cholesterol, same amount of total carbohydrates, and pretty much the same amount of protein. So if you were just to look at calories and macronutrients, so nutrients that provide calories, you would say that these two products are equivalent. But when you actually look at sodium content, you can see that the frozen one, they only had 125 milligrams of sodium, while the canned one, they had 380 milligrams of sodium. So 3 times the amount of sodium that you could find in the frozen version of these peas. So we need to be careful, because sodium, as we know, does not provide any calories. But it does affect your blood pressure. So sodium intake is one of the major risk factors for high blood pressure. And we know well that if we reduce sodium from our diet, our blood pressure can improve. And by improving our blood pressure, we can reduce the risk for stroke, but also heart attacks. Now, just a little bit of salt. Often we confuse salt with sodium, which are not necessarily the same thing. Salt is well, technically it's called sodium chloride, and this is just because there is sodium and chloride. But typically, when we ask for salt, we don't ask for sodium chloride; we just say salt. But how do we convert sodium into salt? Very simple, very easy. You just take the amount of sodium in a specific product, and then you multiply by 2.5, and that's when you get the amount of sodium chloride, or the amount of salt. And what is the recommendation? How much sodium should we eat to reduce a risk for hypertension or improve blood pressure in those who actually have hypertension. In the United States, we consume approximately 3,400 milligrams of sodium per day, which equal to about 8.5 grams of salt. And just to look at teaspoons, we're talking about almost 2 teaspoons of salt. But the guidelines are actually very different. The recommendation from the dietary guidelines are that we should consume no more than 2,300 milligrams of sodium per day. And if you actually have hypertension or high blood pressure, this number should be even lower than 1,500 milligrams, which equal to approximately 1 teaspoon of salt. So we actually, in the United States, we're eating almost double the recommended amount of sodium that we should eat with our diet. And so it's really important that if in case you're not doing that already, is that when you go do your grocery shopping, you start looking at the nutrition fact and you don't focus just on calories. You need to start looking also at other nutrients, particularly sodium, especially if you have hypertension or you have a strong family history for hypertension, so you're at an increased risk for it. And need to be very careful about the amount of sodium that we're eating. Because often we think that sodium is only contained in the salt, and so by cutting the salt from our diet, we fix all the issues. Certainly that's helpful, but we need to look at the amount of sodium in some of the food that we buy. Very interestingly, often when I talk to our patients, they think that, or even myself before, I thought that sandwiches could be a healthy choice. Potentially as a substitute for a meal. In reality, the major source of sodium in the United States are actually sandwiches. So sandwiches can be very unhealthy, and I'll show you in a minute how we can actually maybe make it a healthier choice. And then, of course, there are so many different sources of sodium, but sandwiches remain the number one. And just to give you a little bit of perspective, when you eat 2 slices of thick crust pizza with pepperoni, that is accounting for almost 2,300 milligrams of sodium. That's actually the same amount of sodium that we should eat throughout the day. And remember that it doesn't matter what salt you're eating, if it's a table salt, any salt, that could be the fanciest salt in the world, the amount of sodium is exactly the same. So it doesn't matter if it's a very cheap or a very expensive salt, they will still have the exact same effect on blood pressure and risk for cardiovascular disease. So here, going back to our sandwich, you can see here that we have 2 sandwiches with the exact same ingredient. And in this part, we have a higher sodium choices. And here we have the lower sodium choices. So you can see that at the end of the day, you can have the exact same ingredients, except you can choose the lower sodium versions and save approximately 600 milligrams of sodium per half, in this case, half a sandwich that you're eating. So extremely important to start choosing the right food. Start looking at sodium when you buy food and look for the ones that have a lower amount of sodium. Here's a little more detail. This is a full day of a full diet for 24 hours. And on the left in gray, you can see this is more of a typical American diet. And at the end of the day, we have approximately 4,600 milligrams of sodium. And so in this slide that you will be able also to look at later, you can see how by making healthier choices, you can have a diet that is lower than 1,500 milligrams of sodium. So extremely important. And one of the major recommendation that I would give you is to avoid pre-made meals. A lot of food meals, especially the microwavable meals, they tend to have a very, very high amount of sodium. And so my recommendation is to try to cook or prepare your meals as much as you can, because you can really control the ingredients and the amount of salt that you're actually including in the food. But why all this food have sodium? Well, for a number of reasons, but generally speaking, when we go from a less processed to a more processed food, we have a dramatic increase in blue here of sodium and a decrease in potassium. Potassium is another micronutrient, so it's a nutrient that really doesn't provide any calories, but has a very strong effect on blood pressure. While sodium increases blood pressure, potassium reduces blood pressure. And where do we find potassium in our diet? The major source of potassium in our diet are fruits and vegetables. So that's why one of the recommendations is to increase the consumption of fruits and vegetables to at least 4 to 5 servings per day, non-starchy vegetables. And you can see that when food are processed, there is a huge increase in sodium. Look at roast beef compared to corned beef. There is a great increase, a significant increase in sodium content. Look at cucumbers versus pickle. You have a huge increase in sodium. And so these are reasons why every time we eat, especially processed food, we are likely increasing the amount of sodium that we are eating in our diet. How can we reduce sodium? How can we reduce salt in our diet? Often patients say that if they don't have sodium, their food doesn't taste as good, right? And so we need to be smart and we need to find solution alternatives that can still make our food taste good and yet reducing the amount of sodium that we're eating. Typically, I recommend to cut on sodium or salt a little by little. Don't just cut all your salt from your diet from one day to the other, but just start doing it slowly. And hopefully within a couple of months, you might not even need to add any salt to your diet. In fact, you can start using more herbs, you can start using more pepper, and you can use salt alternatives that can definitely be helpful to reduce the amount of sodium in your diet. Now let's switch gear and let's talk a little bit about fat. We know that sodium does not provide calories, but it affects blood pressure. What about fat? We know that fat it's not all the same, right? And so we have healthy fat in our diet and unhealthy fat. Unhealthy fat is the fat that is typically mostly coming from animal sources for the most part, and that's called saturated fat and trans fat. Trans fat are actually coming from industrial processing. But regarding saturated fat, look at what is the major source of saturated fat in the United States again. We find the sandwiches here that everybody thinks that are a healthier choice. In reality, again, we need to be very careful about our sandwiches because they can become very healthy, but they can be very, very unhealthy as well. And what are the foods that are rich in saturated fat? And the reason why we really want to cut saturated fat from our diet is that because they increase the cholesterol in our blood. Unfortunately, the bad cholesterol, what is called the LDL cholesterol. And saturated fat can be found mostly in red meat. And when I talk about red meat, I'm including not only beef, but also lamb and pork. Those are considered red meat because they have a very high amount of saturated fat and for their typical chemical composition. But also when you eat white meat, like for instance, chicken, you need to make sure that you're not eating the skin because the skin is actually the part that contains a higher amount of saturated fat. And you can see here a list of food that unfortunately, including butter, which is also another major source of saturated fat in the United States, as well as cheese and dairy. And for this reason, when you eat dairy, the recommendation is to use the low-fat dairy because we're cutting on the amount of saturated fat that we are eating. Similar to saturated fat, but actually even worse, trans fat. Trans fat are used particularly in the industry for the processing of their food. And if we have some limit amount of saturated fat that we can eat to 10%, less than 10% of calories from our diet, there's really no recommendation for trans fat other than eating zero. We should not eat trans fat in our diet because trans fat have been strongly associated with the risk for cardiovascular disease. And so that's why when you look at a nutrition fact, you should choose for the ones who have the lowest amount of saturated fat and the lowest amount of trans fat. So, but if we don't eat saturated fat, what kind of fat should we eat? And remember that when we looked at, for instance, fat that we use in our diet, such as butter or olive oil, canola oil, those foods are composed of a number of different fatty acids. So they can be healthy or unhealthy. For instance, here, I wanted to show you how some of this fat, like coconut oil, butter, palm oil, that are actually very, very popular because often we think that those are a healthier choice. In reality, in green here, you can see that coconut oil and butter, they're pretty much almost completely made of saturated fat, so the bad fat. So we should not eat those fat. Well, we should try to switch to the right part of this figure, to those fat that are actually rich in mono and polyunsaturated fat. So the healthier fat and the lower saturated fat, parts such as olive oil, canola oil, peanut oil, and those are the ones that really we should use in our diet, and possibly really don't use at all this fat here on the left part of this figure. So again, love it. Use more unsaturated fat, and these are found in olive oil, canola oil, fatty fish. Remember, when you eat fish, we should eat the fatty fish and not the lean ones, because the fatty fish is the one that contains what is called omega-3 fatty acid, which are beneficial for a number of reasons, particularly reduced cardiovascular disease, but also tree nuts, possibly unsalted or lightly salted tree nuts, but avoid the salted ones. Avocado is another source of healthy fat. And then these are the ones that we should limit and completely lose it, the ones who are rich in trans fat. But why is that? Well, we know very well that if we switch saturated fat for monounsaturated fat and polyunsaturated fat, there's been a strong data suggesting that we might be able to reduce the risk for cardiovascular disease, but overall mortality. So we should increase the consumption of these healthier choices and reduce the consumption of these other ones. The American Heart Association updates periodically their website, where you can actually go online and for free download hundreds of recipes. And those are healthy recipes that still taste really good. And so I strongly encourage you to go on their website. Not only that, they also have videos that you can learn how to cook if you're not necessarily a proficient cook. And then something that I think is very important and many of my patients benefit from is to track your food intake. Because it's really hard, especially at the beginning, to understand how much you're eating. And so you can download apps from, if you have a smartphone or like an iPhone or Android. One app that I often recommend to use, it's free, it's called MyFitnessPal, and you can just download it and you can add the food that you're eating. And at the end of the day, you have the result, a report that tells you how many calories you ate, how much sodium you ate, how many saturated fat, and how many proteins. So that's extremely helpful. And if you were able to fill that out for a few times a week, and when you go to talk to your doctor, actually show them what you were able to do, that's extremely helpful, because then we can make some adjustments to your nutrition, to your diet, based on what you typically do. And then lastly, Dr. Turlington mentioned about the importance of moving more. And yes, we need to move more. We know that by increasing physical activity and reducing sedentary behaviors, this is another risk factor that is emerging in the last few years by using, for instance, a standing desk. Right now I'm presenting here, but I'm actually standing. And then you can increase physical activity and you can potentially reduce the risk for cardiovascular disease. And so the 2019 guidelines developed by the American College of Cardiology and the American Heart Association to prevent cardiovascular disease in individuals with risk factors really recommend, like Dr. Turlington mentioned, 150 minutes per week of moderate to vigorous physical activity, or 75 minutes per week of vigorous intensity physical activity. And what do we mean with moderate to vigorous? Moderate to vigorous, it's typically an activity such as walking, biking, dancing, doing yoga, recreational swimming, and those are enough to activate your cardiovascular system and possibly reduce your cardiovascular risk. Now, what is really important, and this has changed in the last physical activity guidelines just 2 or 3 years ago, is that every minute counts. In the old physical activity guidelines, really the guidelines suggest that you needed to do at least a bout of at least 10 minutes to be counted in those 150 minutes physical activity per week. But now every minute counts. So if you can do 2 minutes of brisk walking while you're at work, that still counts within your 150 minutes of physical activity that you have to achieve at the end of the week. So extremely important. Other things that you can do for physical activities, count your steps. Count your steps on your phone, on your watch, if you have a smart watch, and try to increase that amount by 100, 200 steps every day. The ultimate goal would be to achieve at least 10,000 steps per day, but recent research suggests that if you're able to go above 4,000 steps per day, especially in older adults, that's already associated with a significant cardiovascular benefit. So don't think that sometimes 10,000 steps is too far from what you are, where you are right now. But every few thousand steps that you can increase every month, that's really an improvement of your health overall. And I think I'm done right now. And so I'm happy to take any questions with Dr. Turlington and Pauline.
Wonderful, wonderful job. Thank you so much, Dr. Carbone, Dr. Turlington. This has been a fascinating discussion. I've got lots of notes here that I've been jotting down that I can't wait to share with my family members and friends in that same age group. Dr. Turlington, like you mentioned, like in your 40s. But, you know, we have some questions that had come in and, you know, some really good questions. Like, you know, you mentioned, Dr. Turlington, that, you know, men aren't coming in for their checkups and seeking that preventive care. How can we encourage them to get those numbers? I really liked that guide that you had. That, you know, how do we get the men in our lives to take control and get those numbers?
Well, you know, I think frequency, it should be at least on a yearly basis. They should go in to see their doctor and ask those questions about my cholesterol, about my blood sugar, you know, like Dr. Carbone says, maybe you can show some of those, you know, with the app on your phone to show your doctor to engage them in conversation. But how do you motivate them? Well, that's a little bit trickier. I think exactly like he said, maybe taking that little sheet I gave you or having that app on your phone or whatever it is and saying, look, you're only taking 4,000 steps. Maybe we should go for a walk together or look, you know, your blood pressure was in that 137. It's good, but not great. And use that as a spark. Say, you know, you're right. I heard these talks. We've heard this, but it's not quite to where it is. Maybe that would be the spark to go see your doctor or talk to a nutritionist or somebody else about what other options you may have.
Yes. Dr. Carbone, would you like to add on to that?
No, yeah, that's I agree 100%. And sometimes if you really have no idea how good your diet is, and I'll just talk about the nutrition part, it might be good to see a dietitian just once. Often people think about seeing a dietitian just because they need to lose weight. In reality, you can see a dietitian to improve the overall quality of your diet, even if you're healthy. I wish I saw more healthy individuals to prevent a lot of issues that we see. Often, you know, I get referred or I see patients very, very late when their disease have already progressed. So I think the earlier, the better. So I think that's key, prevention. So we don't have to wait to see something to act on it, but prevent it. And diet is really a risk factor too. So if you have an unhealthy diet, even if your blood pressure, it's still good. We want to prevent that blood pressure to get worse.
Yes, and that's a perfect transition, you know, because we'll hear friends share, oh, I'm even too young for heart disease. I'm too young to have a heart attack. You know, Dr. Turlington, you mentioned, oh, you know, people come in and just say, oh, it's probably just heart reflux, you know, spicy food, you know, and so we've got to get that message out there that we need to get our younger audience. I thought it was staggering that 20 to 34-year-old age group, really, we could really target in and harness that. Really appreciate that you shared that. And so we've only got a few minutes left, but I do want, Dr. Carbone, I really appreciated your discussion too on salt does not equal sodium. And, you know, thank you for sharing that slide with us and, you know, what we can do, because I didn't know. I think it's just, you know, that's what I love about doing these seminars is that I always get something back. So before we wrap up, I know there was a question that came in and we can go to that if we have time, but is there anything additional you want to add to like sodiums? And there was an app that you guys have just mentioned in this dialogue. What do you suggest? Like, are there any like free apps that you can give to our viewers? Mention to our viewers that they could download. I know you mentioned the AHA 7, Life Simple 7. And was there anything else? Any other apps?
An app that I often use myself and a lot of my patients use is called MyFitnessPal. And it's free. There's also a version that you have to pay for its use, but the free version, it's more than enough. And really, at the end of the day, you can see whether you were able to be under those 2,300 milligrams per day. And it's really nice because it also gives you a weekly average, so that you can see maybe, if one day you ate a little more, as far as within your weekly average, you were able to stay below that 2,300 milligrams, that would be good.
Yes, I'm glad that you mentioned that number. I had a blank right there. I wanted you to share that too. So thank you. We are at time. We have, just covered so many good things. And of course, this is going to be on demand. So if you missed it or you want to share it with a family member, with a friend, you can do so. Dr. Turlington, Dr. Carbone, thank you both for joining us tonight in this discussion. You really highlighted the importance of knowing early warning signs for heart disease and how early detection can increase positive treatment outcomes and prevent more serious heart disease. For more information about heart disease, please visit vcuhealth.org/heart and follow VCU Health Poly Heart Center at VCU Health Heart on Facebook. Once again, thank you so much for joining us tonight. We'll see you next time.
Thank you.
Thank you.